So today I'm going to focus on the medications that we use to treat kidney cancer and a little bit about clinical trials, because every medication that is on the market today, from the over-the-counter stuff to anything we can prescribe, is there because patients like you guys participated in clinical trials. So these are my disclosures and a little outline of what we'll discuss today. So probably preaching to the choir, you may have heard it already, but as you know, renal cell carcinoma originates in the outer layer of the kidney. There are about 82,000 new cases in the US each year and 14,000 deaths, unfortunately, attributed to this disease. It represents about 2 to 3% of all cancers, so certainly not the most common, but by far not the rarest either. And by far the most common type of renal cell carcinoma is clear cell disease. Now, this is showing my age a little bit, but when I began my training, we had two options to treat kidney cancer, advanced kidney cancer: high-dose IL-2 and interferon alpha. And both of these drugs were extremely toxic. In fact, about 10% of patients who received these drugs died from side effects of the treatment. The treatments, unfortunately, only helped about 10% of the patients as well. And all of the patients had very, very, very severe side effects. Today, we're in a much better situation, thankfully. Things have evolved rapidly over the last 15 years or so as we have a better idea of what drives kidney cancer, what causes kidney cancer, and we've designed drugs that actually get right to the source, right to the target. So since December of 2005, really, is when we started seeing these new agents hit the market. And it has been a flood of new drugs, new classes of drugs, and new combinations since that time. There are really two main types of medications which we use to treat kidney cancer. And often my patients, when they're first diagnosed, are surprised to hear that chemotherapy is never used to treat renal cell carcinoma. Which is wonderful, which is really wonderful. So the two main type of medications we used are targeted therapies. Now these are smart bombs. They're pills that target the cancer cells. And what they do is they disrupt lines of cellular communication. And for the most part, they stop the formation of new blood vessels. So in order to grow, cancer has to have a blood supply. And if it doesn't have a blood supply, it makes its own. It's a process called angiogenesis. And the majority of these targeted therapies work by stopping that process of angiogenesis. The other type of therapies that are widely available now for kidney cancer are immunotherapies. These boost the body's immune system to fight cancer by uncovering cancer cells that are hiding from the immune system. I trained at MD Anderson, and when I was there as a fellow, every Tuesday, we had lectures. They were called academic Tuesday lectures in a lecture hall very similar to this. And there was always a guy who sat in the back named Jim, who was a little bit disheveled, a little bit long hair, a little bit avant-garde. And he would always rave that the key to cancer was in the immune system. And we were learning about targeted therapies and chemotherapies, and we just thought Jim was a little bit off. He worked in the lab, and that was Jim Allison, who's won every single major prize in science today, including the Nobel Prize for the development of immunotherapy. There's a PBS documentary called "This Is What a Hero Looks Like." If you want to hear more about his life, but his mother died of cancer when he was very, very young, and at that time he made a decision to devote his life to trying to find a cure for cancer, and he developed immunotherapy. And arguably, his work has led to the biggest breakthroughs in cancer of history, really. And so, this is where the immunotherapies come from. And the way they work is pretty interesting. So, under normal circumstances, we probably develop cancer multiple times throughout our lifetime. And our immune system is surveilling for abnormal cancer cells, just like it surveils for viruses or bacteria or other germs that aren't supposed to be there. And most of these cancers are picked up by the immune system, killed, and we never know they were ever there. Never form tumors. They never really cause any problems whatsoever. But what Jim Allison and others found is that in advanced cancers, many of these tumors find a way to get around the immune system. And so under normal circumstances, white cells, T cells that attack tumor cells, have a little on-off switch that works very similarly to the light switch on the side of the wall there. And this is important because when these cells go to attack a healthy tissue, like our liver or our lungs, our liver and our lungs can just hit the switch, turn the cell off and say, I'm a good cell, don't worry about me, go find somebody else to attack. Tumor cells develop little fingers called PD-L1 and PD-L2 ligands that can interact with the light switch and turn the T cell off too. That's a bad thing. That's a bad thing. You don't want that to happen. You don't want the tumor cell to be able to turn off the immune system's ability to kill it. And so what these amazingly smart folks decided to do is they were going to develop antibodies that either bound to the light switch called the PD-1 receptor, or the little finger on the tumor cell called PD-L1 or PD-L2 ligands, and essentially stop that interaction between the tumor cell and the T cell. It's analogous to putting a big piece of duct tape over the light switch so your kid doesn't turn it on and off all the time. But it works. It works for a lot of patients. Not everybody, but it works for a lot of patients. It also can cause some side effects because when we rev up the immune system to fight cancer, sometimes we rev up the immune system so much that it starts attacking a tissue. And this is called an immune-mediated side effect. It can very much mimic an autoimmune disease. And patients will often say, okay, well, what does the side effect look like? Well, my answer to that is anything that you can dream of that ends in itis, these drugs can cause. And it's true. It's true. Because these drugs can inflame any tissue. And if it inflames lung tissue, that's called pneumonitis. It might look like a pneumonia. If it inflames liver tissue, that's hepatitis, autoimmune hepatitis. It can inflame the eyes, the brain, the heart. These are rare side effects, but they do occur. The good news is that for 99% of these side effects, we can reverse them with a high dose of steroids. And often we can go right back to the immunotherapies that led to the side effect in the first place, and they don't necessarily cause the same thing again. What is challenging about these side effects is they can occur at any time after a dose of immunotherapy. They can occur a week after a dose of immunotherapy. They can occur months after your final dose of immunotherapy. So what makes it challenging is if a patient walks into the urgent care center and says, I'm having a cough and shortness of breath, the doctor there, rightfully so, is going to think, well, gosh, maybe this patient has a COPD exacerbation or a pneumonia or COVID or, asthma or who knows. And 99% of the time they're going to be right, but they're definitely not going to think, could a drug the patient took months ago cause a side effect that's now affecting them today? This side effect is treated very differently than we would treat those other things. So I always tell my patients on immunotherapy, if you have any new symptoms, call us right away. And I've picked up the phone, called many ER docs and primary care docs and say, I did just this past week, and say, hey, this could be a side effect of immunotherapy they took months ago. So in terms of when we use these medications to treat kidney cancer, it is still a truism that if you can resect a kidney cancer, if you can surgically remove it, surgically remove it. That is the most important aspect of this. Dr. Arcott right here and I work very closely together. I haven't been in an OR in well over a decade, so I'm the medication guy. But I'm always thrilled when I can send a patient to Dr. Arcott to have their cancer surgically removed, because when we do that, we're often doing it with an intent to cure. But we can use these medications after they're done with surgery. And one way that we use them is what we call adjuvant therapy. Adjuvant means after surgery. And so especially in patients that have a high risk of recurrence. Maybe they had a very aggressive cancer, maybe lymph nodes were involved, their cancer may look very aggressive under the microscope. We can give immunotherapy to try and prevent their cancer from coming back. There are really two drugs approved in this setting. One is an old targeted therapy called sunitinib. It never really worked well in this setting, and it's pretty toxic. But we also have a drug called pembrolizumab, or Keytruda, which is approved in this setting, and it improves survival. So in the studies, after patients underwent surgery, we looked at 2 years following surgery, and the patients who received pembrolizumab, 77.3% of them were alive without disease, compared to 68% of them after surgery who did not receive a year of immunotherapy. And so, we often offer this to patients, and it's an individual choice if they want to take the therapy or not. So, approximately 25% of the patients who who present with the disease have metastases at the time of their initial diagnosis. So, these patients are not curable, and about a third of the patients who undergo surgery to remove cancer will develop metastases at some point after surgery. So these are the patients who come to me who really don't have a curative option, whose surgery is not possible. And so what do we do? Well, as I told you, when I first began my career, we did high-dose IL-2 or interferon alpha. Today we've got a lot more options, and primarily we have combinations of either immunotherapies and immunotherapies, or immunotherapies and targeted therapies. And so these are 5 different combinations that we have available, and patients often ask, well, which is the best? Well, the best one is the one that works for you. And we don't know that until we give it a try. We've actually done some research in trying to figure out ahead of time which one works for each patient, but it's never really panned out. We really just have to try and see how it goes. The nice thing about these combinations is that they work well. So, for example, in the Keynote 581 study, it's the CLEAR study, this actually included a lot of my patients. I was the principal investigator here in New Orleans for this study. We gave patients a combination of lenvatinib, which is a targeted therapy, with pembrolizumab, which is an immunotherapy, and we saw a really nice response rate. 71% of the patients had at least 30% tumor shrinkage on this combination. But more importantly, in my mind, is that we achieved what's called a disease control rate of 95%. So 95% of patients had at least stabilization of their disease, which we consider a win, or some type of tumor shrinkage. Only 5% of the patients treated with this combination had tumor growth. And so, as an oncologist, when I started my career telling people, hey, I've got a therapy that might work for you 10% of the time, versus now sitting in front of a patient that's newly diagnosed and being able to say, I've got a therapy that has a 95% chance of working for you and keeping your disease at bay, it's a very different feeling. It's a very different feeling. And I'm very pleased to be able to offer this therapy to our patients. So a little bit about clinical trials, because as I mentioned to you, every drug that's available today is there because we did a clinical trial on that drug, and often we did many clinical trials on that drug. On average, patients on trials tend to do a little bit better than patients who are not on trials, and that's for a couple of reasons. One is because when you're on a trial, the FDA requires that you be monitored much more carefully. You're assigned a clinical trials research nurse who's checking in with you very frequently, and often you may be getting something that is going to be the new breakthrough a year or two or maybe more later. So I often like to tell my patients on trials, you are receiving the medicine of tomorrow today. You're kind of getting a little sneak peek, if you will. And the NCCN guidelines, which are what we practice by in this country and really around the world, except in Europe that have their own set, strongly recommends clinical trial participation when feasible. Now, not every patient qualifies for trials. The trials have very strict criteria of who can enroll and so on and so forth. But we're always thinking in our mind, is this patient a potential clinical trial candidate. Now, there are a lot of myths about clinical trials that are out there. One is patients are going to be treated as guinea pigs. And the reason I do clinical trials is not primarily to advance science, although that is an important piece of it. It is to bring my patients the best therapies we have available. And so we're not treating them like guinea pigs. We're just trying to find the best treatment we possibly can for them. And when surveyed, patients who have participated in clinical trials often say it was a very, very positive experience. They don't feel like guinea pigs. Clinical trials are for patients who have run out of options. Well, we do use clinical trials in that setting, but we actually use clinical trials in every setting in patients who have curable disease or others as well. Patients may receive a placebo and not treatment. It would be unethical for us to withhold treatment for a cancer patient. And so we may use a placebo, but never to withhold treatment. And so what I mean by that is if the standard of care is drug X, we may design a trial in which half the patients receive a new combination, drug X plus Y, like so a new combination, and the other half receive drug X plus placebo. And so they're still getting the standard care that they would normally, but we would never just not treat a patient and give a placebo. That would be totally unethical and would not fly with any institutional review board that approves these studies. Clinical trials are more expensive for the patient. Actually, the opposite is true. In the state of Louisiana, we have Louisiana Revised Statute 22-1044, a law which I personally helped amend, and that states if you are a cancer patient on a clinical trial, your insurance company has to cover all costs related to your cancer care with the exception of the experimental drug. And that's a fairly unique law here in Louisiana, but it's actually financially better for many patients to be on trials because their insurance companies don't get to decide what care they're going to receive anymore. And participation in clinical trials is not important. Well, boy, if you just look at those drugs approved in the last 15 years, I think we can say that that's not the case at all. So a little bit about how clinical trials work. So drugs are first tested in a lab, usually in plates of cells. Tens, thousands, hundreds of thousands of new compounds come out every year, and only a small portion of those actually make it through the first set of testing in the labs. And those that do are then tested in animal studies, usually small animals first, like mice, and then larger animals to help us better define the toxicities and the dose. And the first time drugs are given in humans, those are called first-in-human trials, and those are phase 1 studies. And phase 1 studies really asking what's the best dose, what are the toxicities of the drug, what are the side effects, and I actually founded the only dedicated cancer phase 1 program between Houston and Birmingham, and we've done hundreds of phase 1 trials through that program. These are highly sophisticated trials which are monitored like you wouldn't believe by the FDA and the sponsors of the trials. And often these trials are enrolling 3 patients worldwide at a single dose level, and then we move on to other dose levels. Phase 2 studies enroll a few more participants that by this time we know what dose of the drug is appropriate, and we're really asking the question there, how well does this work? The phase 3 studies ask the question, does this work better than the best thing we have today, than the best drug we have today, and we compare the two. And then phase 4 trials are after the drug is approved, and that asks the question, how does this work in patients who might not have been able to get on the trial? Maybe they were too weak to be on the trial, they were considered too old to get on the trial, for whatever reason. How does it work in the real world, so to speak? So this is an example of a currently open trial we have at Ochsner. This is called the Pedigree Study. And so what this does is it takes patients who are newly diagnosed with inoperable, advanced metastatic clear cell renal cell carcinoma, and everybody who enrolls in the trial gets 4 doses of a combination immunotherapy. This is standard of care. And then we look at how the patient did after that. We do a set of scans. And if the patient cancer completely went away after those scans, then they continue to receive a maintenance immunotherapy. That's considered standard of care. If they didn't respond and their cancer grew, we switch them to a completely different type of therapy, a targeted therapy, and that is also considered a standard process as well. But for the majority of patients whose cancer didn't go away completely, but didn't grow, so it either stayed stable or shrank a little bit, we randomized them. And so that's really picking out of a hat, not a literal hat, it's a computer that assigns this randomization. But half the patients receive immunotherapy maintenance alone, which is the standard thing to do, while the other half receive a combination of immunotherapy and targeted therapy. And that's a little bit different. We don't usually use two drugs in combination for maintenance therapy. So that's the experimental part here. So our hope and what we expect to happen is that patients who are receiving the combination in the maintenance phase will do better than those who are receiving the standard one drug in maintenance. And so it'll be a few years before we know the results of the study, but we've enrolled probably about a dozen patients to this study, and they're all receiving therapy per the protocol. So here are my final thoughts. So these new combinations of targeted therapies and immunotherapies are giving our patients longer lives, far longer lives, with fewer side effects than the more traditional therapies we had before. We still can't cure a lot of these patients, but we can give them many years of a productive life. But we still don't know exactly how to sequence these drugs. Which should we use first? Which would use second? And that's why we're doing studies just like this one. And we also are not very good about knowing which combination or which drug is going to work for which patient. I told you we tried to do some things in research to pair up patients with drugs. It's a little bit of trial and error, even if you're not on a clinical trial. You give a patient a drug and see if it works, and then adjust accordingly if not. So what we really need is what's called a biomarker. Some cancers have a biomarker where we can take a blood test, for example, and it can guide us. Lung cancer, for example, has lots of biomarkers where we can do a blood test and it can guide us to this is the right drug for this patient, while this is the right drug for this patient. I often like to say that that's the holy grail of renal cell carcinoma, a good biomarker. We don't have it yet. People have been looking for it for as long as I can remember. They're still looking for it, and it's out there. We're going to find it, but not yet. We haven't found it yet. So more research is needed, but the good news is that new drugs are coming out every year or so, giving patients new options, more hope, and better quality of life.